Just a few comments. First of all, I'm emeritus chief of the service. Very proud of that because Bassem can now do that, not me. Second of all, Bassem asked me to be fellowship director. I haven't done anything yet. Um, and lastly, just so we're clear, the sports fellows and the shoulder fellows are pretty much equivalent in terms of my role. And so I just wanted to make that clear because the way we're doing education now is sort of a mixed bag. And we can talk about that later if we want to. But the purpose of this talk is to really give you some perspective on my experience in rotator cuff repair. And I came into my practice in 1990 before rotator cuff surgery was even being done arthroscopically. And when I was one of the first as a chief resident at Mass General and, well, chief resident at Brigham to actually do arthroscopic surgery at all, including subacromial decompression. So some of this is going to be history, some is going to be science, some is going to be some technique, and then I'll have a case if we have time remaining. These are the guys that helped me put this together. This dates back, I don't know, 3-4 years. So I want to put that in perspective. So this is 30 years, this talk. I'm now in my fourth decade. There's been a lot more that's evolved since then. So that gives me some perspective to share with you. Now, like most of you, you hopefully will remember your teachers. Hopefully, I'm somewhere on that list. These are some of mine. Upper left is Charlie Neer, then Christian Gerber, who really defined the science of rotator cuff repair, then Russ Warren, who was really a pioneer in developing techniques, along with Steve Snyder and Steve Burkhart, as you see here, and then many others in the lower group here. You see Brian Cole and Peter Millett and Matt Provencher, all of whom were sort of my students. So I have some conflicts. I'm not going to talk about any products in specific here. This is really an old list. It's not up to date, but again, I'm not going to talk about products. I'm going to talk about principles. So all of you want to understand really, how do you go from the left to the right? Now, you can do that open, you can do that arthroscopically, and the message here is that we started with all of these techniques that seemed to be original arthroscopically. They were original open. And the techniques came actually before a lot of the science. So if you go back to 1963, these were really the major founders and developers of shoulder surgery, and every single one was an open shoulder surgeon, not an arthroscopic surgeon. And Neer wrote his book on shoulder reconstruction in 1980 that talked about many of the techniques that we now apply arthroscopically in doing rotator cuff repair. These are a young bunch of guys that inspired me early in my career that developed a lot of these techniques. Some were really against arthroscopic surgery. Charlie Neer over here, Charlie Rockwood over here used to call it the instrument of the devil. Bob Cofield never did any arthroscopy, and neither did Matson. Russ Warren and Rick Hawkins were more early adopters. So if you look in the British Journal of Bone and Joint Surgeons, which used to be the British Journal, at the top 100 classic papers, you'll notice that Neer had 5 publications in the top 100, 2 of which were on impingement. The fascinating thing is the concept of impingement that Neer developed was wrong. And we now know better about what causes rotator cuff tears, and it's less extrinsic compression than it is intrinsic failure because of mechanics across the joint and across the rotator cuff, which I won't get into in great detail here. But because of his influence, you can see from 1996 to 2006, over 10 years, a 254% increase in acromioplasty, which we now believe is largely not so necessary, except in a few instances. That's really important to bear in mind because there's usually a rise and a fall of enthusiasm in something. And it's typically the case that it's partially right and partially not right. And so this led to 78.3% increase in ambulatory orthopedic procedures by 2010, and it's multiples higher than that now. And you just, perhaps if you went to Grand Rounds, you heard a little bit of a lecture about why we're moving into that disruptive approach to healthcare. Now, I don't know, 4 years ago when I gave this talk, if you Googled arthroscopic rotator cuff repair, you got 1.3 million hits in a half a second. In reality, you get a whole lot more than that now. And principles, you only get 200,000 hits. Point being that people are more enthusiastic about the procedure, but a lot less aware of the techniques required to make it work. So if you looked at a rotator cuff tear market analysis about 5 years ago or more. 2 million visits to physicians annually, estimated at about 4.5 million per year, some estimates. 400,000 cases done, that's many more than that now, and about $5 billion in direct surgical costs, not indirect, with a compounded annual growth rate of 7%. It is much more now, and I'll show you why that's important to us here at Mass General. So if you look outside the United States, you can see here the rate of growth is even more steep. And a lot of the innovations that we use came from outside the United States. Now, this was an analysis I did, I don't even know, maybe 10 years ago, looking at codes for rotator cuff repair and who provided them. And if you look here, each of these is an individual surgeon with their specialties listed right here. So shoulder surgeons, sports surgeons, hand surgeons, all shared in this. The question is who provides value, and by now those of you doing a fellowship understand the value of a fellowship in education, because it's really the case if you look at the outcomes here, the better outcomes are over here, not over here, because these folks have passed their learning curve, and whatever technique they use, they've developed over time, and they've learned what works and what doesn't work, and these folks over here have not. And yet our hospital encourages volume and throughput, not quality. Sorry, that's just how it is. That's my opinion. If you look at our outpatient surgery center, where many of you work with us, I did an analysis when I went to business school looking at the breakdown of the volume of procedures done here. And so you can see that shoulder surgery, which is minor and major over here, is 18.8% versus 7.4% some years ago. And really the leader was hand surgery, right? But if you look here at RVUs, which is an expression of the amount of work being done, then shoulder drives the revenue in the organization from a institutional point of view when you add up these two areas here compared to all the others, which are lower RVU production. And so the reality is what you're learning about the shoulder translates into dollars significantly so for your institution. Now, if we can, guys wonder about all the time, which is what's the difference between a small, medium, large, and massive tear? This is a picture from Christian Gerber showing what he measured as a massive tear, and Cofield created the concept of size mattering. Now, it really doesn't matter because we're all different sizes. So a 5-centimeter tear in him is different than a 5-centimeter tear in him. And which tendon's involved is the most important. And so here's Ellman, who was one of the fathers of arthroscopy, with his concept of A, B, C, and D. And then if we go back here, small, medium, large, massive, and then, of course, Cofield. Now, when Cofield looked at all the rotator cuff repairs that he fixed, I want to point out to you here that only 10% were massive. So how do you come to any conclusion about what really works in such a small percentage of all the rotator cuff repairs that are done? And yet this became the basis for how we would treat these things. And in fact, when Christian Gerber looked at the results of massive repair, he came to this conclusion that there's no universal agreement on the definition. And typically it involves 2 or more tendons, not one tendon. So what is an irreparable tear? So this is work of Philippe Collin when he asked doctors at the EFORT meeting in 2015 how they determine if a tendon is torn that can be repaired. And 11 of 15 surgeons said, well, I can do it before surgery. And these are all the different ways they do it. Not really in agreement with one another. Is it migration of the humeral head? How many tendons are torn, fatty atrophy, etc.? And then 4 said, no, I just put the scope in and I can fix anything. And in fact, Burkhardt published lead article in the Arthroscopy Journal, I can't remember how many years ago, 92 cases of rotator cuff repair with excellent outcomes, regardless of tendon tear or chronicity or size of the tear. Now, I think most of you will, by the time I'm done with this, probably agree that that's not a great approach. Now, this for me is the single most important article that I've ever read, and it was published by Dominique Meyer and Christian Gerber, and it looked at the geometry of the tear from the standpoint of the magnitude of retraction and the fatty atrophy. And what they pointed out in short is that if the fatty atrophy was 2 to 3 and the tendon length was less than 15 millimeters, the failure rate was 92% by MRI post-op. But if the tendon length was greater than 15 millimeters, that's this distance here, it was only 33% failure, okay? And actually, if you look into this, they concluded that the combination of the two was better than one alone. And so if you look at tendon length less than 15 millimeters, you can see the odds ratio of a re-tear of 9.4 and sensitivity and specificity pretty high. And then if you look at Goutallier scoring for Goutallier 0 or 1, fatty atrophy, versus 2 or 3, you can see the significant difference here when you combine tendon length as well. And I try to look at this before I endeavor to do a surgery, because I hate going into the surgery and saying, well, maybe I'll do this, maybe I'll do that. I like to know exactly what I'm going to do and what products I'm going to need. Then Steve Burkhardt came along and published on partial repair, and this is from his article, just fixing the posterior part of the rotator cuff, which is a nice idea. But his results were exactly the same as what he said he would get when he did a complete rotator cuff repair, which leads me to believe that many of his repairs failed up here, but did well back here. Okay, so there is a role for partial repair, although we don't know exactly. Now that we have so many other things to do, we put SCR in here or some other graft or what have you, adding cost. Nobody's ever really compared these two effectively. And then this wonderful article by Philippe Collin and colleagues, and you may recognize some of these folks, Pat Bernard, who is an Arthrex champion, and Gilles Walsh, who is not, who's an open surgeon. And they looked at the relationship between the geometry of the rotator cuff tear and the potential for repair and also for function. So they came up with type A through E. And so if you look here, when you have an upper subscap tear and a super tear, you usually have good range of motion versus weakness or paralysis here if you have the combination of subscap and supra, and you can look through all of these and see this. And when I look at these patients, I ask myself, is this patient that, or is this patient that, or is this patient that? Because those also factor into whether I'm thinking I'm going to do a repair or some other approach rather than just a repair. So now if we get to the actual surgery, then there are steps to success. And the two things that I think are probably the most problematic for surgeons are number 3 and number 5 here, which is mobilization and releases and suture passage, and management is a big issue as well. Certainly, I hope after working with us, you'll know how to visualize the tendon. But you are the single most important factor for the success of the patient in the process decisions that you make and how you actually do the actual surgery. And there's no one best way to do it. So basic approach that I think is worth at least reinforcing is that whether you do it in beach chair or lateral decubitus is up to you. I prefer beach chair, but the portals you use are critical to see. And for me, the primary viewing portal is a direct lateral portal in most cases because this is what you see. That means you start here and you make accessory portals as needed, and it doesn't matter how many you need because you don't want to compromise your access to the tear and to the repair of the tear. So here's a video from Laurent Lafosse demonstrating looking from posterior underneath and how you can see the delamination. He's between the two layers. And this gives you some insight into what you're dealing with. And this isn't a very big tear, but nonetheless, you understand there are two components to the tear. And I personally like to abrade the greater tuberosity from this view because when I go in the subacromial space, referencing of the anatomy is much easier. I can see exactly what I prepared already before I'm going and doing the next step. And here you can even pull on the tendon and see how you're going to bring it back. And of course, the biceps is diseased here, which is important to understand. In many instances, we ignore the biceps, which is bad for the patient. So now here's a posterior view after subacromial decompression. And I want to point out it's really important that to get this view, you have to remove all the bursa. Clearly, you see the footprint. But a lot of people started to do arthroscopic repairs looking from this view and didn't really appreciate the delamination of the rotator cuff or other elements of the tendon tear that are seen much better when your scope is viewing where the shaver is right now, which is why that's the way I generally do it when I'm doing my repairs. And just showing you how we try to remove the bursa to get a good view of the tendon before we start fixing things. So again, Lafosse recommended tear configuration assessment and evaluating mobility for a tension-free repair. Others did long before him. You pull on the tendon, you can see the muscle here. It's why it's important. You understand that the muscle isn't so elastic when you have grade 2, 3, or 4 changes to the muscle, so you can't put the tendon back where it belongs. If you look here, here's an example of a stiff chronic tear where it's not very mobile. Now, you may do releases to try to fix it, but the loads across the tendon are problematic in terms of healing. And that's why chronic tears often don't do so well. But you can see from posterior to anterior is much better than the other way around. And then below, similar assessment. So I do all these things before I'm even moving forward with repairing. Okay. Here is a very nice view from direct lateral demonstrating significant delamination of the tendon. And there's usually a deeper layer that's more retracted medially that doesn't go as far laterally. And some people will go so far as to not only do releases of these layers, but to repair the medial layer independent of the deep layer, independent of the superficial layer. And I try to put them together, but place my anchors at the medial part of the footprint and incorporate the two layers at that point, not overloading the tendon repair. And then if you look here, you can see, again, how we can remove the bursa to see much better the extent of the deeper layer that I have to address here, and then assess mobility and do releases as needed. Now, I want to point out that this concept of releases this is from Neer's book, and yet we do it arthroscopically, thinking that we are doing something original. This, again, is another one this is from a Biliani article, and you can see here we're releasing the coracohumeral ligament, as you can see right here. That's necessary to mobilize the supraspinatus, and going to the base of the coracoid and doing that in stiff cuff repairs can be very, very helpful. And that you can see the coracoid right here. And I wonder how many of you have actually seen that in your fellowship. And it's important to understand that sometimes something that looks irreparable becomes repairable when you do these kinds of releases that are really predicated on understanding what we used to do open, or at least having the ability to watch somebody do them. And once I've done this, the mobility is dramatically improved. There's a rotator interval. The subscap is this way. The supraspinatus is this way. Here you can see an interval slide. Sometimes it pays to separate in this case, the supraspinatus from the infraspinatus, so that one can slide independent of the other, because it allows you to repair each individually. This, again, is from Neer's book here, doing the so-called interval slide. We do this from time to time. I think some of you have seen me convert a U-shaped tear into an L-shaped tear. That basically improves mobility and how you can repair the tendon. Again, you want a tension-free repair when you do this. Suture passage is another basic art. I like to use the clever hook. There are many devices you can use now. Companies create these things to promote their products. The nice thing about this, as I'll show you in a little bit, is the value of the so-called lasso loop. Here is something called, you probably know the espresso. This was the cappuccino. Believe it or not, this was one of the first retrievers. And this is the basis for the ideal suture passer from J&J. And then Arthrex came along with its lasso, its suture lassos, and then Smith & Nephew with its own version of that. Here you can see the espresso. And then all of you are familiar with the Scorpion and the First Pass, and you name it. Every company has their version with a different name. But this started first with this startup company that was acquired by Mytech. Sadly, they didn't scale it. Now you can see how we're incorporating the superficial and the deep layer together, which you can do with a clever hook, or you can do with one of these devices, so that you're not missing part of the rotator cuff. In this instance, this is shuttling the suture back through both layers. And the anchor, as I said before, is relatively medial on the footprint, because I don't want to overtension the deeper layer when I'm doing this. Then suture management is a bit problematic. This is a picture taken by Brian Cole many, many years ago when we were on a boat together in Alaska. That's a separate story. And so when you wind up with all these anchors and sutures to repair things, how do you manage them? This is one of the techniques that I like when you're dealing with the edge of a tendon tear, particularly when the tendon isn't very good quality. Creating the so-called lasso loop, which works very well with this clever hook device, which every company has revised, is a very nice way to provide great stability, because it holds the collagen fibers perpendicular to their length. So I'm going to finish that part here, and we are now, 8:21. So I have a case to show. And in the meantime, if there are any questions before I show that case, I'm happy to answer them. Anybody? I'm not going to call on anyone. I'm too tired to do that. Nobody. Everybody gets it. Everybody knows it.
Dr. Warner, can I ask a question?
Sure.
How do you think about the rotator cable when you're repairing cuffs? Is that something that is just it's just a piece of the structure and that you don't worry about as much? Or do you think that a partial tear is really just restoring that cable, or partial repair is restoring that cable, or is there anything different that you think about that?
Well, there's a lot of observational research suggesting that if the tear is within the crescent, within the cable, that patients do very well with conservative management. Unfortunately, patients come with pain. And so, the cable is seen more clearly in some than in others, to be fair. But as a general rule, if the cable is disrupted, then you're extending past the supraspinatus in most instances. And those people are the ones that have, I think, more symptoms. But that's a very anecdotal comment. That's not a real scientific analysis, basically. Do I look at it and know where it is? Yes. You know why I like to know where it is? Because those who have been with me and they've seen me do transcuff viewing portal, when I do a posterior Bankart or something like that, I try to place the portal through the muscle tendon junction, which is medial to the cable so as to not disrupt the tendon. And I've never had a rotator cuff problem by doing a transcuff portal, which I thought of based on what I learned from Dini Patel many years ago for the transpatellar portal. So I figured, why not make a transcuff portal? You see great when you do that. So that's my thinking about the cable.
JP, question. Good morning. Uh, are there cases where you go in, even though you feel by MRI you can repair, but you get in and it feels like the tissues are not good enough to repair despite all the tricks that you showed, and you do anything differently intra-op?
Yeah, of course, there's always exceptions. There's not, never say never, never say always. That said, you get pretty good information from the MRI from the standpoint of what you can see of the tendon, what you can see of the muscle. But sometimes you're surprised and it is an issue. I have to say that I'm personally not a big fan of tissue augmentation, though I know a number of you use it because Evan O'Donnell did a nice study showing how much cost you add to the repair. The data that's available so far, unless people can quote something that I missed, is not very strong. But this is a huge moneymaker for the vendors that provide these things to us without a lot of evidence of their support. And so some folks will look at that, Bassem, like you might, and say, I think we should do a tendon transfer, and that's fine. Others will look at it and say, well, we better augment that because we put collagen there, it's going to be better and it's going to heal, or maybe regenerative, or all the different things that are out there. I haven't been swayed yet by the science available for that. So yeah, I mean, it certainly happens, but it's relatively rare for me in my way of thinking. And the problem is patients do well when they tear the rotator cuff. We know that from Yamaguchi and Gallutz's work. And I want to emphasize that classic article that they published in JBJS was a testament to how bad they did rotator cuff more so than it was the tendon issue. And many, many years ago, just to share this anecdote with you, it was Charlie Neer who presented at the International Shoulder Meeting at the Waldorf Astoria in New York when I was a fellow in 1989 of his debridement of large rotator cuff tears and how successful they were. And after his presentation, Charlie Neer walked quietly to the microphone and you could hear a pin drop. And he said to everybody, he announced who he was, Charlie Neer, and he said, in my opinion, the definition of an irreparable tear says more about the surgeon's skill than the patient's tissue. And so we have these two groups, right, where I'm the great surgeon, I can fix everything. And some of it is technique related. And the other one is I don't need to fix anything because they don't heal anyway. And as usually the case, it's in the middle, right? So for sure, I can understand your perspective. What we don't have are good scientific studies comparing anything. They're all level 4 cohort studies. And Bandari would say they're more or less worthless. So would, for that matter, Ionides, who gave grand rounds here not long ago.
Thank you.
Any other questions?
I have one, Dr. Warner.
Yep.
Just real quick, kind of in the same vein. When looking at MRIs to determine repairability, going into that surgery, trying to have a plan, do you have like an exact cutoff or like even a vague cutoff of how close to surgery you want that MRI to be, like how recent the MRI is, and the threshold after which you say we just need a new one?
Yeah, it's difficult to say. We know from animal studies what happens when you cut a tendon to the muscle. That's very, very rapid fatty atrophy. But people show up in our offices at different points in time, and you may wonder, why is this person's cuff not muscle not so atrophied. And there probably is some element of the retraction that affects things. So if the cable's intact, or if it just hasn't retracted so much, the muscle, lasts longer. And that has to do with the compliance of the tendon you're repairing. My big concern, well, I'm 100% certain, and most of you would probably agree, that you see some people, when you operate on their stiff tissue that's thin and or it's just brittle, and other ones have nice, elastic, healthy tissue. That happens over time. That doesn't just happen right away. So if someone falls and ruptures their rotator cuff and says, I don't have time to do it now, how long can I go before I fix it? I'm going to make a comment here, and it's largely opinion. But, I say to them, I think probably a few months is a good idea. But if you come back in 1 year, I don't know what things are going to be like. I would definitely get an MRI then. Now, I want to separate two categories of tears, and that is anterior tear and superior posterior tear. If you tear the subscapularis, I can tell you the fatty atrophy is much faster than with a supra because it retracts significantly. And a subscap rupture, in my opinion, is the closest thing you get to an urgent situation to repair. Because if that lingers for a year, I have cases for sure, workers' comp cases that were denied where I got an MRI before and after, and you can see rapid fatty atrophy. And when you try to fix it, it's not very good quality. I think the subscap is different than the supra, for example. And in those instances, I'm much more aggressive in recommending that should be fixed. I would never say to someone, don't fix it, unless my shoulder is normal, I'm 100%, I have no pain at all, I don't want to do anything. But I'm more aggressive with subscap than the other configuration tears.
Dr. Warner, in that same vein, just from a practical sense, then, do you change necessarily your approach then for anterior superior tears or subscap ruptures in patients that are older, like without arthritis or very minimal arthritis, and they've got, somebody who's maybe 70 or 72, as opposed to in their mid-60s?
Well, so we didn't really talk about the demographic factors and biologic factors that can affect healing, like smoking, like diabetes, like age, like things like that. The problem here is that, and I can tell you, being in that category that you just mentioned, age is quite variable biologically. We all see people who are 60 or 70 that look remarkably young, and those who look remarkably old. And so the person you're treating is the person that lives in here, not the person that has a chronologic age. And so it doesn't change my approach. If somebody doesn't smoke, they're physically fit, they don't have diabetes, and they have a repairable tendon tear, I don't say you're too old to fix the tendon. I try to fix the tendon. Now, does it heal less effectively than younger people? We know that's the case. That doesn't mean it's not worth trying. At least that's my approach. And that, again, is opinion. That's not so much science. Okay? So we are 8:30. So I have one case to share, which kind of goes along a little bit. It's not edited so much, so I may bump us through it. But let me see if I can. Oh, hang on one second. I got to bring it up here. Give me 1 minute to bring it up. Screen. Why am I not getting out of here? Hold on one sec, guys. Okay. Let me do this. And let me bring this up. Okay, let me share my screen. Go. Okay. So I like this idea of case-based presentation. Can you guys all see that? Yes? I'm going to take the silence. Yes. Okay.
Correct.
So this guy here, let me go back for a minute. So this person here is a case. Evan O'Donnell, and when he first came, helped me put this together. Let me let this run for a minute. So the story of this person is a 54-year-old guy, bodybuilder, right shoulder pain, got worse 3 months before, but we had somewhat chronic, over the lateral deltoid, pain 6 out of 10, difficulty sleeping. Therapy didn't help him. He underwent a right arthroscopic rotator cuff repair and biceps tenodesis some years before. So he did well for 3 years until 3 months ago, right? That's his story. So there always has to be a story. So I won't dwell on it too much, but his exam, which is coming up here, his exam showed pretty good range of motion, but he was weak. Now, one of the things we don't measure like this anymore. I used to have these strength assessment devices that all broke. I had to pay for them myself. But look at the difference. You know, what's 4 plus over 5 versus 12 or 13 versus 18? And 4 for external rotation, 5, let's say 5 versus 10. That's kind of important. And we do all the other exams here. So you know he probably has a superior cuff tear to some degree. And he wants to be very active. So these are the old anchors that were used, as you see here. The urinal head is centered. There's no arthritis. So you're thinking that's probably pretty good for repair. So of course you want to know what the tissue looks like. And now you get metal artifacts. So what do you do when you get metal artifact? Hard to see the tendon here, but you can see it over here. Okay, that's more than 15 millimeters. I think most of you would agree with me. Muscle quality looks good, but I don't get any other information because of the anchors. So I'm thinking, well, you know, I don't know. Let's stop for a minute. Does anybody here want to do anything other than try to re-repair this? Speak up now or forever hold your peace. Anybody? Tendon transfer, augmentation, anything else? I'm going to take silence as either you all left or nobody wants to do anything different. Okay. So in this instance, here's his shoulder. Here's the markings of where the portals are going to go, just like I showed you before. We always start with a posterior portal. I mean, this is relatively elementary. I don't have to go too much through this, just sort of showing the portals and how we do it. And here's your first view. And when you go inside the shoulder, you see all this sort of crap and stuff in your way. You need to get it out of the way. So the first thing is you want to see. And if you're looking here, I think this is looking from the side, and this is my lateral portal. You see the sutures that are here, and clearly the edge of the tendon. So we make this lateral portal here, and I'm going to work through the lateral portal initially so they can see a little more, but I don't think you can really say for sure what the quality is that I'm working with looking from posterior. So in this instance, I'm going to try to make an incision that's not going to destroy his tattoo. So I'm very thoughtful about the art that people come with on their shoulders. And let me go a little further here. And so once we're in here, we want to take the sutures out for sure to get them out of the way. And sometimes there's a lot of sutures. And then you want to take the tissue out of the way. So we're in the subacromial space now, clearing all of that. So whatever we do to the subacromial space is part and parcel to being able to see. And then if you're doing an acromioplasty, in many instances, it's just to be able to see better. And so I can pull on this tendon, and that looks pretty darn good, don't you think? For the most part, pretty mobile. You got to wonder, why did it tear? Which leads you to understand the questions you should ask when you start, which is a lot to do with how is your aftercare. And if we look carefully, look, there's a deeper layer here. So it's very important I don't miss that unless we can talk about it. Maybe some of you think it doesn't matter. There's been at least one article that said it doesn't matter. I don't understand why it doesn't matter. You can see this additional split here. So Gerber made the point that you want to take away all the stuff that isn't likely to heal that's in the way before you decide on the size of the tear. And so this tissue is very poor. It's just a thin sort of bursal connection to what is actually the rotator cuff. And part of this is feel and part of it is visualization of what remains as good tendon. So now I've got a bigger tear. And here I am doing what I showed you before, going through the superficial layer and the deeper layer. And I usually put the traction suture through the two so that I can, and here I am making sure I get the deeper layer, so that when I pull on that traction suture, I ensure that my sutures from the anchor I placed pass through both layers of the tendon, okay? And so for me, that's the first step. And so in this instance, I'm shuttling it. You can do lots of different things. You can use other devices, but this is just what we showed you before. Then I'll pull on these sutures here, and this becomes, not only is this a useful traction suture, but you can pull on the tendon and see the adhesions you have to release. And furthermore, you can pull the suture in the opposite direction of where you're working to lift the rotator cuff off of the humerus so that it actually is an internal retractor. So here you see the external adhesions, which of course we release. And we go through this very quickly, and I'm not sure if all the fellows are aware how important it is to do these things, but these are the critical steps that Neer talked about. Why would we ignore them when we do arthroscopy? Same thing he would do, except he did it open. And then Biliani after him, and then Evan Flato and a host of others. So you see, here's the supraspinatus right underneath the device. We're back over the infraspinatus here, and these adhesions can sometimes be relatively significant. I think they're not too bad here, but the point is I'm just trying to show you creating the interval. And in fact, if you do a partial repair and then do a tendon transfer like Dr. Elisan does periodically, and I do sometimes, it's important to do all of this anyway to repair what's repairable. And then whether you pass your tendon graft underneath or over, that's Dr. Elisan can comment on that later. But now we have a nicely released tendon here. I'm going to pull on it and decide what direction it's most mobile. The leading edge of the supra is here. There's some adhesions here as well. The coracoid is over to the right, probably at about the 1 o'clock position. And so now I'm releasing the coracohumeral ligament, like I showed before. The coracoid is just medial to where I am. And so these, again, and this is an extra-articular release, exactly what we would do, or what I learned to do open when I was really a fellow, because we weren't really doing arthroscopic cuff repairs back then. Tip of the coracoid is going to be there. The cannula is just over the subscapularis. Personally, I don't have any problem opening the rotator girdle to mobilize and repair the posterior cuff before I repair the subscapularis. Burkhardt, came up with the idea that you should keep them together because when you repair one, you repair the other. But I think I have difficulty to see mobilization and furthermore mobilization of the subscap if it's involved. It's not involved in this case. So now I can see we're quite mobile. We can come from posterior towards anterior. We can come from medial towards lateral. There's a little bit of a soft tissue tether here. Can't remember if I'm releasing that or not, but because that's attached to the subscapularis, then sometimes I'll release that and do an interval slide between the two of them, and that's exactly what I'm doing here to make sure that I've fully mobilized the tendon so that when I repair it, there's no tension on it at all. Okay, and so again, the coracoid is just medial over here. I don't want to drop.
JP,
Yeah.
JP, can I ask you a quick question?
Yeah.
So as you're doing this, are there certain things that you look at to talk about the quality of the tendon? That this is tendon good, it's gonna be okay to fix?
Yeah, well, quality is sort of a qualitative assessment, isn't it? Is there a way to really structurally say how solid it is or whatever? This is elastic, it's mobile. There are two components that need to be repaired together. I can bring it back to where it belongs without significant tension on it. That, for me, is good quality tissue. But, poor quality, good quality, fair quality, I think that's in the eye of the beholder, unless somebody knows something I don't know.
Okay, it's fair enough.
All right. So we're just going through this release. I'm going to speed us along a little bit here. So once I've done all that, and let's see, where are we? Here's a very nice animation from the FOSS. Remember, I put the anchor somewhat medial, not quite that medial. And now you can do a variety of things. You can use different devices. I happen to like when there's 2 layers of tear. I like to use the clever hook device here. And again, this is LaFosse's original video demonstrating this. I probably would come from posterior towards anterior, but you put the clever hook in and you can retrieve your sutures as you wish. As you'll see in a moment, it also is a wonderful way to do lasso loop configuration. Now, I also use Scorpion and I use Passport and all of that. And these are like golf clubs in your golf bag. You don't always use them, but you use them when they seem to be more appropriate. But think about the mechanics of what you're doing and the tension you're putting in the tendon. The method doesn't matter. It's the principles that really matter. And so, again, he's mostly using the clever hook here because that's what he created and how he does his thing. And, I used to have this on the website so people could see, well, how you do a repair and everything. I don't know where it went. It sort of disappeared. But patients like to see, well, how are you going to fix this? And you can see how elastic the tendon is. I'm not sure I'd use that exact configuration. And then you tie your knots and repair it. And this was for patients to see how we do it. You can see how the lateral edge everts and why there might be a rationale for doing a double row repair technique, which we'll talk about in a moment. So here we are putting the anchor in. I have to tell you, medial row anchors, there's just it's all derivative. It doesn't really matter. They're all more or less the same. Nobody's proven that vented anchors are better than non-vented anchors or what have you. Again, I may be wrong. You may have some information I don't have. Please feel free to share that at the end, but that's just my opinion that I'm sharing with you. So we've done that. The anchor goes in. You don't have to see all of that. In this instance, I like to use the clever hook like LaFosse showed. And here I'm going through the deeper layer as well. And then I'm simply going to retrieve the sutures, and I'll go through all of this because I'm going to get towards the end here. And you wind up with this nest of sutures. Well, retrieving the sutures out portals, parking them away from where you're working is essential to avoid tanglement and confusion in this. So you'll notice that they're pulled posteriorly, right? And I'll work from the back or the front, however. Now, I have no problem putting the passport in and doing a scorpion, using a scorpion here, or first pass, or whatever you want to do this. But one of the nice things about the clever hook is if you think the tissue quality is problematic, particularly at the edges of the tear, you can do this so-called lasso loop, which I'll show you in a moment. And so I try to avoid many, many passes. So I'll put multiple sutures through one through one hole in the tendon. But as we come from, and I usually work from posterior towards anterior when doing a posterior superior tear like this, as we work through this, going from posterior towards anterior and all these sutures, which I'm pulling out of the way, you can see here the loop that I create and how I retrieve the corresponding suture. And that grasps the edge of the tendon significantly stronger than a simple suture coming through the tendon. Now, it was Gerber that talked about Mason Allen stitches, and people tried to do that arthroscopically, which is a bit more complex. Structurally, this is not equivalent, but it's nicer. And I'm right at the front edge of the supraspinatus, as you can see. And I'll usually do double row repair posterior, or put in my horizontal mattress posterior. And then at the edge of the tendon, I'll do the so-called lasso loop, as you can see here. Again, that's just the influence that I've had from people who have taught me. And again, I pulled the posterior sutures out of the way, so I'm not crossing anything, and I'm pulling these sutures anterior typically, so that when I'm all said and done, I don't tie as I go. We used to do that, and that was a problem because you couldn't put things in because you closed it all off. And then I'll tie the opposite direction, front to back, because when you tie the front down, it's like pulling a sail down, and now it's not flopping up in front of you, and it's easy to tie the remaining sets of sutures from front to back rather than the other way around. And I'll park these out of the way because, of course, I'm not sure yet, am I going to do a double row or single row or what have you? There's no question double row is more expensive, but one of the problems with the way we look at things is we compare apples and oranges. Small tears are not big tears. So small tears should cost less than big tears. And yet there's one code, which is completely illogical and ridiculous. And frankly, somebody like Evan O'Donnell, when he returns from fatherhood, should do an economic analysis looking at the actual value we create by using more anchors in the bigger tears versus the smaller tears. Then that would be a basis for arguing about what we get paid, or the RVUs. So here you can see how we've repaired anteriorly, and we're simply retrieving the corresponding sutures here. You don't have to watch me tie knots. I don't care what knot you use as long as it's a locking knot. Some people prefer not tying knots and just fixing medial and lateral and bringing it down with a lateral anchor. I don't like that because I want multiple points to avoid a failure. If one point fails, the other points don't. And then once we've done all this and we've tied all these, I'm at the point you all probably are very familiar with, putting a lateral row anchor in. And what you use and how you use it, that's really up to you. But the purpose is to increase the surface area of contact of the rotator cuff against the tuberosity, because it's logical, the greater the surface area of contact, the better the potential for healing. So low tension on the tendon, greater surface area of contact is really the principle that you use. Now, I'm not sure that maybe one of these anchors is Arthrex. It doesn't matter which company you're using. It's the principle that matters. And while one may have developed a technique or whatever, technique scale, and just like they showed in Grand Rounds, that's the basis of disruptive innovation when you do things cheaper. Actually, it's not really disruptive innovation. It's creating value. You do things cheaper. And here's this nice double row repair as a revision surgeon. I think most of you would probably think that it's a pretty good chance to heal, given what you've seen in terms of the quality of the tendon and what we accomplished. So I just wanted to show a single case. I don't want to get too crazy about it. Maybe now we can just have a conversation because we have lots of time left. Well, 15 minutes left. And I'm happy to entertain any thoughts, arguments, points, questions, whatever. So have at it if you're interested. If Dr. Mazaka is here, you always argue with me. So why don't you say something? No picture, no voice. Okay.
Dr. Warner, I have a quick question. For your lasso loop suture, this is more technical, obviously. For your lasso loop suture, do you incorporate that into and tie it down to your medial row anchor, or do you just tie it around the side of the lateral row?
Yeah, so you're usually using it at the edge of the tendon, and so mostly I'm using it in upper subscap tears or leading edge of supraspinatus. So I'm not trying to lateralize with it. I'm just trying to anchor down the tendon. It's typically somewhere closer to the medial edge or the center of the footprint, not so much laterally. If there really needs to be contact across both the medial row and the lateral row, two anchors, if you will, then I won't use a lasso. But lasso precludes really doing a lateral row.
Perfect. Thank you.
Sure. Anybody else? Nobody. Okay. Bassem, do you have a comment relative to? Let me make a comment, and then you respond to it, please. My personal view is that, and tell me if I'm wrong, it's faster to do a tendon transfer than a rotator cuff repair, like I just showed. What do you think, Bassem? If you're still there, or maybe there you go.
No, I'm still here. I'm still here. So I agree with you that I do believe that tendon transfer is quicker than rotator cuff for me, because usually if you have a deficiency on the rotator cuff, you have the space open. It's very simple to pass an Achilles tendon and fix it in place. The only reason I ask you these couple of questions throughout this presentation is because I feel a lot of the augmentation for me, I don't. Right now, with what's available, I don't use. My augmentation is lower trapezius. So when I feel the quality of the tendon, when you talk about the quality of the tendon, whether from the pre-op MRI or intra-op, if it's not good, I will not try to take chances. I'll go ahead because we know that lower trap work. The surgery now, we are very comfortable with it, so we'll do it. So anyway, for me, for what you mentioned before and even now, I feel I always have it in my backup. If when I look at MRI, there's anything questionable, I talk to the patient about it and go ahead with it.
So let me just comment on that. I think we are all victims of confirmation bias. We tend to pay attention more to what we believe and less to what we don't believe. And
yeah, fair enough.
Our decision making. This is the nature, human nature, right? This is why I prefer this or that, or you do this or that, or whatever. At the end of the day, none of that matters except for one thing. What's the outcome? And I'm sorry, we don't do a great job of measuring outcome the way we should measure outcome. The reason we don't do a great job is because we don't have time and we don't have money and resources. And that's an important point, because I would say we work in the home of Codman here, and the institution has failed miserably in honoring his commitment to measurement. Case in point was how long it took to get patient IQ actually approved. This is not a priority at the home of Codman. And that is the answer to everything we're talking about here. And I think towards the end of my career, it's the saddest thing I can remember about this organization. The lack of willingness to enforce the principles Codman put in place, which is the only thing that matters is the patient's outcome. And that includes structurally what we achieve, but also how they feel. And we don't measure systematically enough, at least not until now. Gus, any comments?
No comments. I know you're sad, and we're working as hard as we can to make you happy.
It's got nothing to do with you, my friend. You, like me, are just one of the waves in the ocean. The institution is a giant rock we all hit. And
no, we got to keep fighting. Got to keep fighting, buddy.
So
keep
let me ask
fighting.
you a question. Let me ask you a question, Gus. Since you're a champion of the healing potential of bursa, can you share with us the evidence you have to support that? Because we haven't talked about that here, and that's part of the science that I ignored. But you're the scientist doing that. What can you tell us about how that helps us with what we do when we treat these patients?
Well, I would say the science that we have on it shows that there's a lot of progenitor cells in the bursa, which was very surprising to me. Those cells happen to be more active, more proliferative, and more migratory than, say, concentrated bone marrow, which is what we compared them to. I think the biggest block to what's happening right now is our ability to reproducibly implant the bursa and keep it where it should be. We tried to do it with an autologous clot, fibrin clot that would go away in 6 weeks. That was very costly. and time consuming and also variable. So really, I think the potential of the bursa, I think, is great. I think the problem that we have right now is really the end part, which is just the application, having it go into the place where you want it to go and stay there.
Right. I wanted to share with everybody, I don't know how many of you watch Grand Rounds, but it was an interesting, if not somewhat eclectic, Grand Rounds. But the speaker talked about Clayton Christensen and about disruptive innovation and tried to relate it to healthcare. So let's talk about rotator cuff for a minute. One of the interesting things that Christensen wrote about that our speaker didn't mention was the application in healthcare as it relates to the concept of what we're being paid to do. Christensen believed that what you and I do with rotator cuff repair shouldn't be fee for service. It should be fee for outcome. Understand what I'm saying? We don't get paid for outcome. We get paid for the service we provide, whether it works or it doesn't work. I think most of us take pride in what we do and believe that we get good outcomes. But we're underpaid because of this regression to the mean of service. There would be a complete change in the way we manage patients if we were accountable for the outcomes of what we were doing. As long as the payment rose to a level that was fair for success, if we would then be able to accept that we wouldn't get paid for failure. And that would eliminate a lot of the horrible revisions that we get all the time and the issues that we have to deal with. It's a bit interesting to me that wasn't mentioned. But I don't know, as you go through your careers, the fellows that are here, you'll realize that around you will be people less well trained than you, and you're getting paid exactly the same as they are, probably with better outcomes than what they're getting, because that's the way our healthcare system is structured. Here, look at all the steps and efforts we make to be better. As you become better and better and better, there's no differentiation between you and anybody else. Kind of an interesting point. I think about it from that point of view because I'm always trying to think about the value potential, the value proposition of what we're doing. Any other kind? I want to ask one more question. I don't know who's left here, who remains, but is anybody brave enough to say they use tissue augmentation and why they feel it makes a difference? I'd be very interested to understand that. Now, I know that there are, because we looked at 700 cases. And maybe those people are not on this presentation here, but I'll bet some of you are. Does anybody have a comment on that? Because I don't want to beat it up. I want someone to say why they think it's good. Okay. Seems like nobody. If there's nobody here, I want you to remember I asked the question. Okay. I didn't ignore it. Bobby, you going to say something? You just popped up.
Yeah, I mean, so I've used the Regeniten for recalcitrant revision cases where I felt like the tissue was a little less than ideal, but still worth repairing, and very selectively. Probably of the 70 or so, or to 70 to 80 rotator cuffs I do a year, probably on like 3 per year. So really low rate. I think the probably that one to me has the only potential upside of just delivering biology but no structure. I think the structural grafts, in my opinion, are not ideal, and I stay completely away from them.
Do you know how they do when you use Regeniten?
No, they do about the same. The problem is,
does it mean they worked or they didn't work, or they healed, they didn't heal?
I couldn't. So as we've been following these, I mean, it's not a high number yet. So following these, they don't seem to have any change to the mean. So I don't think it's really adding any value.
Okay. So I think it's important. We should have the discipline as a group to do that work. We really should have. We don't have for research assistants. We don't have enough time, but somebody should look specifically at this group to understand, are we creating value when we're doing this? Not just because we owe it to the institution to do that. I don't really feel like we owe the institution anything, frankly. But I do think that we can create value by identifying what works and what doesn't work. The only argument I have here is that when we do all that work, it should at least be supported by the institution, which it isn't. And it should also be the basis for a collaborative approach, which I call co-management and gain sharing. Because that's what we're doing. We're co-managing and trying to steward resources being used to improve the bottom line of the organization, to help the organization. So thanks for bravely sharing that. we're going to identify. I mean, if I have the time and energy to do it, and Evan comes back into play, since he's the guy that does this, we're going to try to identify everybody's cases that we measured the cost of, and see what actually happened to the patients in terms of their outcomes, reoperation rates, how they're doing, etc. To answer that question. Okay, we are 4 minutes away from the hour, so I'll give you 4 minutes back, and thanks everybody.